Uh, why? क्या सीधा कर दूं? नहीं, छोड़ दूं? Four, four other. थैंक यू वेरी मच फॉर द काइंड वर्ड्स। बट ऐसा है नहीं, सारी एनर्जी इन्हीं की है। यही सब कुछ ला रहे हैं, हम लोग सब साथ हैं इनके, टीम वर्क की तरह सब लोग काम कर रहे हैं। ओके। uh, there is a study held in John Hopkins that 157% cases are being increased anesthesia outside OR. Anesthesia outside OR. So you people are doing sedation outside OR. That is important because there are lots and lots of complication can happen in your theaters. Yeah, this is ASA guideline. ASA guideline for anesthesia. I am not talking about anesthesia because you people are not anesthetists. You people are just giving sedation. So you should know oxygen source is important. You know, oxygen source is important wherever you are doing work. Oxygen source is important and suction source. Suction source is also important because you people are doing suction, and most of the time we need suction as well. You can leave it in monitoring and drugs. These are sedation equipment. All these things are important before giving any type of sedation in any setup. These things are important. Electrical supply, light source availability, and adequate. There should be adequate space to run, to see the patient, to manage emergencies. Emergency card, trade assistance is important, very important. Trade assistance. You can see we are giving anesthesia standing at the lower end of the patient with the foot end, and somebody is sitting at the head end with the jaw thrust, head tilt, and chin lift, and continuous suction from mouth, which you are introducing in the stomach in the form of air, in the form of water, and we are my assistant is doing suction, continuous suction. Otherwise, it will go into the vocal folds and cause laryngeal spasm and desaturation. Okay, these are the drugs which we use during sedation. Propofol, this is not your drug. Don't use this drug. This is our drug. We are trained to introduce this drug for the sedation, and there are lots and lots of side effects of this drug, like apnea. If there is apnea, you cannot manage this. So don't use this drug. The other is ketamine. This is not your drug. Dexmedetomidine is a very good sedative drug, but it can cause some side effects like bradycardia, which will not be treated by atropine. So don't use this drug in wrong doses. We can use this drug by giving different dilutions. We are using this drug here. You can use midazolam. Before start of this talk, I was asking what are the drugs which you are using. We are using midazolam and nalbuphine, which is a standard drug which you are using. But be careful that this is not the standard to 2 milligram midazolam, 2 milligram pills or 3 milligram pills for each and every patient, whether he or she, whether what is the body weight, what is the comorbid in this patient, which is very important. If the patient is diabetic, hypertensive, or any other disease, you can alter these drugs. We are doing this. We are doing this 1 milligram, 0.5 milligram, 3 milligram. We are doing this according to their body weight, their comorbids, which is important. So these are the some level of sedation which we can use. level of sedation, minimal sedation, moderate sedation, deep sedation, and general anesthesia. I think you are doing this and this. Like when you are giving minimal sedation, responsiveness is there. You can talk to the patient. Are you all right? Airway is unaffected, spontaneous ventilation, and cardiovascular function is normal. This is minimal sedation by giving midazolam and nalmefene. And moderate sedation, you can see purposeful responsiveness is there, no intervention airway, and adequate spontaneous breathing. The deep sedation is required by the anesthetist. But if you are giving deep sedation, standby anesthetist should be there to maintain airway in case of any emergency. Or of course, general anesthesia should be given by us. Uh, looks like busy slide, but very important. Shared airway. In GI, upper GI endoscopy, there is a shared airway. Shared airway increases risk of aspiration because vocal folds are there, trachea is there, esophagus is there. You are going into the esophagus, and trachea and vocal folds are also there. Sometime, you people are not very gentle. Sometime, I said two times, and sometimes. Then patient starts coughing, bucking, and desaturation started. So that is why you should be gentle. Introduce your endoscope. We are there to control our patient, and please be gentle. Positioning prone and high risk of positional injury. Sometimes positional injury is also there, like leg or hand or conduct of anesthesia by difficult person. Starvation guideline. Patient is, of course, patient is NPO, but you push air in the stomach, you push water, there are some secretions, some blood, some clots, some collection by pseudopancreatic cyst, and sometimes food is also there. All these things can create problem at the time of procedure and in the recovery. So your recovery should be very good, monitored with trained staff, because any time patient can vomit, and patient can vomit all these things during procedure too. That is why we are doing continuous suction from the mouth. Procedure specific complication, GI bleeding. You can handle this patient usually elderly, frail, multiple comorbids. Sometimes patient with bilirubin of 20, 30, 35, 40. When their bilirubin is 30, 35, 40, the other system will also not very good. So we should be very careful with this patient. So monitoring should be pulse. I'm writing this, I wrote this in capital letters. Pulse, blood pressure, SaO2, saturation, ECG, and respiration are must by each and every person of this department, of this house. And monitoring of cough, hiccup, movement. We are seeing this. If there is cough, we should give some more anesthesia, some different anesthesia, some other drug to decrease these reflexes. Sedation and CR. What we are doing here, we are very gentle while doing introducing endoscope, and you are doing silocaine gel over the scope to introduce in the mouth. We are giving injection xylocaine IV 1 milligram per kg to open the response of pharyngeal reflexes to introduce endoscope properly. Pyrolate, injection pyrolate to decrease secretion, mouth secretion. Nalbuphine in recommended doses depends on the patient body weight, age, and comorbids. Midazolam, the three drugs which I wrote in red, it is our drug. We are using this in recommended doses according to patient safety. These complications can happen. Minor complication, I think all of you have seen this: inadequate sedation and anesthesia, post-operative nausea and vomiting, agitation, inadequate post-operative pain control, hemodynamic instability, minor respiratory complication, and all these things. I'm sure all of you have seen this. These are the major complications, and these are serious complications. So you should be very careful while giving sedation during any procedure. To decrease chances of hypoxia and desaturation during the procedure, we are using this device, and it is very helpful. This is high flow nasal cannula. It provide 1 liter, 2 liter, 3 liter? No. It provide start with 10 liter of oxygen per minute and then 20, 30, 40, 60. So the whole lung, the whole lung, this is a lunar interval and this is hypovolar interval. The whole lung is full of 100% oxygen all the time. So the chances of hypoxia and desaturation is very low. We have this instrument in all of our theaters. You can see in this case the 100% lung is filled with 100% oxygen, and with air it is oxygen and 78% of nitrogen. And then the last thing is challenges in the post recovery area, and it is also very important. Tongue fallback, vomiting, inhalation is important in this area. So you should be very careful with your patient. Potentially long transport area, if the because these theaters are usually out of other theater complex. So the Paku area, post anesthesia care area is a bit far away. ट्रेन पाको स्टाफ होना चाहिए, अप्रोप्रिएट इक्विपमेंट होना चाहिए. There should be a support system to discharge patients from this area to home or to HDU या ICU. You should see the GCS. GCS should be 15 before shifting the patient to the home. BP pulse, no pain, no nausea, vomiting, SaO2, respiration, regular activity of all four limbs. These things are important before the discharge of patient. If the patient is going to ICU or HDU, this criteria should be different. And handing over document is must. Handing over document, patient is awake, patient is maintaining saturation, patient is pulse is normal, blood pressure is normal. All these things should be written on a page. Conclusion, that there should be a checklist of each and every patient before and after. Team briefing before start of case. We should do a team briefing that we are going to do only sedation, we are going to do deep sedation, or we need general anesthesia. So the anesthetist should be there. There should be a protocol in each and every unit. Monitoring techniques honi chahiye. Open discussion meeting and set expectation with all of us so that we can improve the quality. Now you can ask any question if you want to.
What advice you would give, ma'am, to endoscopists who are performing in low resource settings where they have no access to trained anesthesia staff? What can they do? Can they run some short courses of endoscopy technicians seconding as anesthetists, or what recommendation do you give, especially in public hospitals?
If you are asking about anesthesia, anesthesia should be given by anesthetist. Full stop. Sedation, if you are asking about
Sedation,
sedation,
ma'am.
yes, you people are trained for sedation. You people are trained for giving a bromicum up to the limit of this. Last time you told me this कि मिडाजोलिन इससे ज़्यादा हम नहीं दे सकते, या प्रोपोफॉल वी कैन नॉट गिव प्रोपोफॉल. You should be trained for this. You cannot give propofol because it will cause apnea. If apnea happens, what will you do? Nothing. Hypoxia. Then how we provide oxygen? छोटे से काम के लिए आया था, hypoxia हो गया. That is why you should be trained for this. But you are trained for GI endoscopy. You are gastroenterologist. Don't enter in our field. Anesthetist should provide anesthesia. Safety is.
May I take question, something you think about. What do you think is mortality related to giving sedation, deep sedation, is acceptable in the procedures we do?
Zero.
I think that's the most important. Can we justify? We can say, you know what, I'm giving in this city. I know people given to give 15 milligrams of Vidaza, 15 milligrams here. Now, they may be getting away with 1,000 cases, not having any. But is it justified that you have one death in 10,000 or whatever numbers you put? To be honest, it's not. these are preventable things. Preventable complications cannot be just whether so if you don't have sorry if you don't have the facility of having someone like that minimum requirement क्या होनी चाहिए for sedation you see आप sedation यूज कर रहे हो मेटाडोलैम और आपके पास इसके एंटीडोट होने चाहिए be honest how many of you have imaginary use so you need to have you need to have resuscitation facility you need to have oxygen you need to have monitoring ये तो होना चाहिए unfortunately we still not paying attention to these. So the idea of this talk and idea of this whole thing is looking after the patient as a whole. That's why consent is important. That's why sedation is important. That's why the touching is important. Procedure तो बात है कि ऐसे तुमने निकाल दिया नहीं क्लिनिक की जल्दी मैं निकल रहा हूँ यार तो तू देख लेना ठीक है कुछ नहीं एस्पिरेट कर लिया वॉमिट कर लिया वाइट who's responsible? You. एंड ऑफ द डे पेशेंट को कुछ होगा तो रिस्पॉन्सिबल फाइल बाकी दुनिया का मुझे नहीं पता यहाँ पे जो है ना सिर्फ और सिर्फ डॉक्टर की पेशेंट कैन नॉट एक्सेप्ट कि ये वो मेरी रिकवरी वाली नर्स सो गई एंड यू कांट रिलाई दिस पाकिस्तान वी आर लिविंग इन आई एम सॉरी जो फैक्ट्स है वो फैक्ट्स है हम रिलाई कर सकते हैं लोगों पे अनलेस यू एक्चुअली सीन देम once you make a team, then it's fine. But you must have a team. You know people who give sedation without resuscitation facility in Pakistan. Yes or no? Correct. Why are they doing that? Are they doctors? Don't they know? Don't they know the scientific?
जैसे गाइडलाइन बताया कि ऑक्सीजन सोर्स जरूरी है सक्षम जरूरी है इक्विपमेंट रिसर्चिटेशन इक्विपमेंट जरूरी है देन यू कैन यूज इट
मैं तो एंडोस्कोपी देखी जिसमें एक सक्शन था तो थोड़ी देर मरीज को आता था थोड़ी देर स्कोप पे लगता था यार बुला दो मान सक्शन मशीन इज नॉट एक्सपेंसिव देयर इज नो ऐसी चीज नहीं फ्लैमाजोल एक रखते हैं जितना भी महंगा है वो एक रखने में कोई महंगा नहीं ठीक है एक एम्बू बैग हो आपके पास आप अपने पास चीजें रखें एक बैकअप कोई बंदा तो देयर शुड बी समबडी हु शुड कम एंड हेल्प यू इफ यू आर नॉट गोइंग इन द हॉस्पिटल I think हमें अपने मिनिमम स्टैंडर्ड्स को वहाँ लाना है जहाँ पे कम से कम ये लोग आए तो कहेंगे यार ओके ठीक है यहाँ हम कर लेंगे चलो चलो लेकिन बहुत सारी जगह ऐसी है so one of the things why we bring you here and what we want to see is that if we can do it trust me you can do it it's about thinking about your patient. I go to their unit, I see things and I say, what should happen? You come back and start work.
आपने ये पेशेंट किया जाके और आपको आप चलेंगे वो दोबारा और दोबारा जब सोचा जाए तो कल कॉल बैक हो सकती है only for diagnosis, yes, लेकिन कोई ज़्यादा होगी नहीं दिया वापस नोटिस हो जाते हैं लेकिन इधर लैब को मेटाबोलाइज हमने जितना टाइम नहीं हो गई
वैसे according to your definition, almost all the units in this are generally anesthesia is not routine. Only you have GA list once a month or once every 2 weeks or so, different department. Normally we use conscious sedation, and in early 2000, I think it was 2002 or 3, there was a very big national audit carried out in the US, where it was found that most of the complications resulted from over-sedation. Just like Dr. Saab mentioned, people are giving 15 milligrams of midazolam, that is totally unacceptable. Nowadays, the acceptable dose for midazolam in people below 70 years of age is 5 milligrams, and above 70 years of age is 2.5 milligrams. We normally use, instead of nalbuphine, we use fentanyl as our main analgesic.
and fentanyl for above 70-year-old is 50 micrograms, and for below 70 is 100 micrograms. So that is your conscious sedation. Most of the staff are required to have BLS, basic life support. When I was in my younger days, I used to do advanced life support, but nowadays I just do the basic life support. And you have access to cardiac arrest team at any time the patient goes off. So that is of primary importance that before you embark on any of these procedures, you should have full backup. And again, it is strict requirement in our case that if we do an endoscopy and you find your stomach is full, the advice is to take out the smoke straight away. Not mess around with sucking it up because you can't suck out food debris. So you should abandon the procedure immediately. Otherwise, you'll have the same problem of aspiration. So we do not use propofol ourselves. That is only the domain of the anesthetist.
So the important point here is that you're going to do it in one sedation. As long as you have that, that is very if you have a backup. ERCP is not an office procedure. You can't do it in a small clinic, put a flow and see how and start doing ERCP. As long as you believe that there should be no preventive care. That's the rule that we must remember also. One mentor told me and advised me earlier today. Would you do the same to your mother? Yes, how you do the same to your mom, your daughter, your brother, your father? Do it. Otherwise, get someone else to stand next to you and help you. Or
Secondly,
take
yeah,
you to a place where you will be comfortable. I will not be comfortable. So, I think one of the things, one of the things that I want to be quiet about, we're not showing you a American system here, we're not showing you British. We're showing you an institution called which has all the so I think more for you to aim for and as I said, if you can get it, there's no reason why.
So I also made an early request that just we can have the system in Pakistan. So the management principles of this institution should be shared with us.
No, that will become very difficult. We are going to do that on the PSG level. Uh, we are actually working on minimum standards. It would not be fair for me to make this a standard overnight. You can aim for this. So what we plan to do is, hopefully you'll have it in this conference, the next conference. We share with you what the minimum standards should be. And everybody who's had that minimum, who has that minimum, will get a certification from PSG. That will also be hopefully in future linked with healthcare connection of each province. And so that becomes now mandatory. But what we would do is we will say that this is the minimum. We give you 2 years to reach this, which is the this is excellence, which you can aim for. So we don't want to make our one a standard when we know that our one cannot become standard overnight in fact. You understand? So you have to take everybody on board, but this is something that PSG will be working on. I need support from youngsters in PSG. You guys need to be active. You guys need to challenge us. What we have missed out, we need to bring. You are much more aware. Your knowledge is much more than what I had at least. With this little thing, you have access to it. I think you should do that.
So, on the same note, I'll see if I can share this document. So, from BSG Quality Improvement Project on ERCP, we published 70 statements, best practice statements or minimum standards on ERCP. So, I think if there's one document that you should aspire to take away from this meeting, is this document. I mean, this is a summary of the 70 statements, which starts from the point you set up a service to the point where you're actually in a position to effectively deliver a service, ensuring patient safety. So it's a long document. I don't think we'll have time to go through all this document. It's open access, so you can just Google it, and then please have it as a document available in your units. And what it talks about is this setting up or an standard operating procedure. But Dr. Afia was already mentioning, those three broad categories of doing procedures with conscious sedations, deep or enhanced sedations, and then GA or full general anesthetic. So you have a very clear protocols in your unit. There are certain cases, and I think in many units, we do have to rely on conscious sedations for level 1, level 2 ERCP, where you're just managing patients with choledocholitis, small stones. But in some situations, that conscious sedations, your window of opportunity is quite small. So your patient then starts to wake up, starts to struggle, and then you won't be able to deliver effective therapy. So you have to have standard operating procedures, policy that is written for you. We talked about individualized consent yesterday. Likewise, every unit, every area has different requirements. So you just need to make sure you take this, but then try to incorporate it in your setting and make sure you are able to establish and deliver an effective service. So that's one. Secondly, I think aaj ka din hai, this is the last day of this course. So if you have any doubts or if there are any areas that you're not clear about, please do not walk away. Oh, I wish I had asked this question. Oh, I wasn't too sure. Day one we said you have to have a very clear expectation. This is a start for many of you, a start of a journey. So breaking it down, say, what was my objective? What did I want to achieve? Have I achieved it? Is there something that I'm still not clear? Please ask. Make sure you have got a very clear concept of at least some basic points to take your service or to take your development to the next level. So please don't walk away with any unanswered questions in your head. So those are the two things I wanted to mention before we discuss some cholangiograms. Any question on that? जी बिल्कुल. These are the minimum standard and best practice documents.
Start ERCP in UK, they have set up, these are the things that you must have or you must be follow, you must follow to achieve for it.
It talks about
If we can share this with
हाँ जी. I think even if somebody can print out these.
we can print it out.
हाँ जी. हाँ इसी अब हाँ जी. ये देखें जी BSG ERCP Quality Improvement Program Minimum Service Standards. हाँ जी. It's available. It's available. So you'll all be able to sort of print it out. Should not be a mess. So are we okay to move on then? Acha, acha. So from my perspective, as I had envisaged ERCP in my early days, there were two main areas where I thought we needed to focus. One was position as we talked about at every step. Wherever you are doing cholangioscopy, you're doing any other interventions, pancreatic therapy, you need to ensure that. And then the second important thing was cholangiogram. Obtaining an adequate quality cholangiogram, interpreting it, and making a decision. Now, there are lots of things that we have to talk about. We do ERC, we do ERP, even in ERCP, you have different levels. You've got a different pathology you're dealing with, intrahepatic, extrahepatic, depending on what sort of population you're dealing with. Is it transplant? Is it living donor? Is it deceased donor? Is it a patient who had a cholecystectomy, bile leak, post-hepatectomy? Many things will influence your practice. As an example, one of the things that we at least see in our patients in our practice, patients who've had hemihepatectomy, if the right lobe is gone, sometimes that cushion available to maintain a short scope position is not achievable. And it becomes really tricky to do that. And therefore, you may end up being staying in a long scope position. So your normal anatomy or your normal image completely gets distorted. What the Vajjiga is like. So you just need to be mindful of what is the clinical context here, what do I really want to achieve from this case, and how do I uh, make decisions based on the information that available. So we've seen lots of fluoroscopy images, cholangiogram during in the last 2 days, where I hope you would have appreciated. So I think there was a case where we had a lot of large stones which were removed, and when we were doing the occlusion or completion cholangiogram, you could see there was a lot of air in the right side, in the right system, and there was still a lot of contrast in the left system. So you had a filling in the left system and a lot of air cholangiogram on the right system that you will not, I mean, not uncommonly you will see it in patients when they're actually lying in their usual prone position. Okay, uh, so nothing to be of concern about. Clearly, you need to ensure that there wasn't a stone which wasn't removed. I don't know who was with me when we did that case, and your colleagues or technicians who were with us ensure that we were able to get deeper into the left side and ensure there was no intrahepatic stone and there was no structure. So you can, and that was ensured, but despite that, that contrast still stayed, and that was due to the position of it. So you just need to be mindful of seeing a contrast in the system and then air cholangiogram, especially in the position that they are in. And now there are a few things that over the years that I've learned, and I think one of the things that I've learned from Dr. Hassan is about this concept of a watershed area in the pancreas. So you know, when you initially trying to get the wire in deeper into the CBD, common hepatic duct, intrahepatic ducts, you will see the wire going and crossing the scope, and then getting into the deeper into the intrahepatic ducts. So you sometimes get that reassurance that the wire has now crossed the scope, so we are heading in the right direction, and then you just keep going. I think one of the key take-home messages, what I learned from his talk or presentation or case is this concept of this watershed area in the pancreas, and that area is in the neck of the pancreas. So that is when the wire would advance, appearing as if it is getting in the direction of the CPD, and then would take a turn. So that watershed area in the neck of the pancreas, if you're not careful at times, and if you're just going in with a wire, you can perforate one of the side branches and can cause pancreatitis. So this is a case, probably would highlight it. Now, this is a post transplant stricture. Patient had initially presented. This was, I think, I believe, these are not my cases, by the way, a living sort of deceased donor transplant. So not what you would see in this part, kind of living donor. So the full liver was transplanted. So there was a stricture at the anastomotic site, which was initially managed, crossed, stented, and then the patient came back for the repeat ERCP. Now, this ERCP was performed by a trainee. They passed the wire, thinking that they're heading in the right direction. It crossed the scope, hit this area, and then trainees just kept on advancing the wire. Now, to be honest, if initially looking at it, it may have felt like that it may be going in the right direction, but this wasn't actually the CBD. This was PD. And then the wire actually crossed the side of the left lateral. So is this the initial image or? No, I think that there should be another image on this case. There was an image before this, wasn't it? Hmm. But there's a
No. This is from not abstract.
this Srisha.
This was Isha presented last year. My only concern is that we need to look at this side actually going into the intraoperative system here. So I would not blame anybody. If I see this wire,
So,
this wire goes like this, but the only worry is if it had gone into the pancreatic duct and it's gone through side branch, then you wouldn't expect it to go like this. So I'm sure if you put the wire a little bit more, might have turned this way. But it certainly looks like here, at least in the left.
so I think can I, yeah, correct, correct, yeah, yeah. So, the, yeah, no, there's another picture. Where's that image gone? Anyways, okay, for the time being, just ignore the wire, okay? Just ignore the wire. And this duct, the filling is, it seemed like as if this is the CBD, but it is not, okay? Then there's another image, we'll see if we can find it, but then obviously the wire was taken out and then got into the direction that they wanted to. The point to make here is that be mindful of this area at the neck of the pancreas, which is like a watershed area, where if we are not careful and then advancing the wire forcefully, it can go through one of the side branches, it can cause leak, it can cause pancreatitis, can cause all sorts of problems. And especially in the setting when they've got a stricture post-transplant, which has been initially managed, we've got to be very careful. So point of what position patient is lying in. So again, as we discussed on the day one, left lateral, prone, supine, because that is going to distort the images completely. So you need all that information available before you can truly and confidently interpret an image. So experience. As I said, the point is if you are in doubt, you then want to get an opinion from your consultant or an expert, but that's where you've got to be careful of. Correct. That's what the impression would be. So it's heading in the direction, but in some cases, at the neck of the gland, it's going to take completely turn toward the spine. Okay, and that's where it can get bit confusing. So just be mindful of when you're advancing the wire, and as it is heading toward the sort of common hepatic duct, intrahepatic duct, if you've got any doubt, any resistance, we don't want to sort of force it.
The important lesson here is the left side. We were discussing the other day, the positions, left lateral position is strict because initially both the ducts go exactly the same. If you're not careful, you can easily think that you're in the CBD, but you'll be in the pancreatic duct. Even otherwise, maneuvering the wire initially, when you're not sure which system you're in, you need to be very careful.
And the other thing would be the case yesterday. The one it looked like it's going moving the wire in there, it's crossing the scope, going up, still look like it's in the wire. But it was a thing, yeah, and then eventually started taking a turn to the other side. Many times, what happens is like even though the bile duct enters the duodenum parallel, pancreatic duct perpendicular, but bile duct is coming this way, pancreatic duct goes in and then takes the turn up. Both could be like parallel to each other for 2 centimeter, 3, 4, sometimes 5 centimeters, something like that. Okay, so just be careful, especially when you are pushing a wire in there, and be very gentle. If there is any resistance and then wire starts bending, just be mindful. It could be in the pancreatic duct and it's stuck up in the side branch, and if you keep pushing, it can perforate that.
Again, another image. I don't know anything about this case, not one of my cases, so it's just an image that I've put up. Again, to highlight the same concept, okay? That how dangerous it can be if you're not careful. What do you see on this image? Is the scope position stable? What position is patient lying in? Okay, and in fact, let me just go back, if you please allow me. You know, there's something. There's something that Dr. Anai mentioned on day one in terms of the patient position. If you're not sure if you had seen the vertebral column here, that might have helped you in ascertaining whether this patient is lying in supine, prone, or left lateral. Do you remember what he mentioned on day one? Fantastic, excellent. So the spinous processes. Okay, as he mentioned, if the spinous process is head on, that would reassure that your patient is not in the in the left lateral position. Clearly, you can't see in this image, but that's what you could have asked. So can I have a look at the spinous processes? It'll be going on the side. It'll be going onto the side. You won't see that head-on position as he explained on day one. Okay. So this is here. You can just probably can't make out on this image either, and therefore you'll have to be clear in your head what position patient is lying in. So
one of the fears we have now from over-injecting a lot of times into different way before. Now we've gone to the other extreme where we're just not injecting that kind of stuff. We're so scared of patient getting pancreatitis. Injecting pancreatic duct is not an issue. It's the amount of injection that you. So if you're injecting and you're not sure, just be gentle. If you're injecting yourself, or if your technician is injecting, then you need to be careful. Filling the pancreatic duct is not an issue. Filling the side branches is an issue. Okay. So if you are filling just to delineate the path to CBD, or you're getting into PD, there's no point continuously doing that without knowing what you're doing. Inject into the pancreatic duct. There's no problem. Don't overfill it. And then decide what you have to do. So I think the fear should not be there about injection into the PD.
I keep saying that I can hear different opinions, but I always keep saying that why contamination from the body is not mechanic that leads the contrast injection to be able to find the main duct. Yes, you don't want to over inject or what we call mesmerization, inject into the just like that. You don't want that, but you need to go pathway of the pancreatic duct. Is there an answer loop there? Is it gonna be like where it's taking the turn and so when you're moving the wire needs to stay in the main duct. That's the main goal.
So again, and bearing in mind, so in terms of there used to be this concept that if you've injected a contrast, your patient is probably more at risk of developing pancreatitis as opposed to the wire. I don't think that is true, or it's a concept that you kind of need to adhere to, that if I've injected a contrast, now I need to think about stenting the PD or otherwise. So wire or no wire, contrast or no contrast, I think your risk is not determined by that alone. Your risk is determined by what is the clinical concept or context. Was this a young female, normal bilirubin, normal initial caliber duct? That is probably category which would put them at a higher risk of developing post-procedure pancreatitis, as opposed to I've filled the pancreatic duct or I got the wire in, I therefore need to make a decision. So I think that decision, that should not guide your decision to place a prophylactic stent or not. One of the other thing again, I've obviously learned from Dr. Hassan is that you then decide if you're going to put a stent in, how far you want to keep the stent. Do you want the stent to then cross the neck of the pancreas or not? So I think mostly, which I have kind of done, I hope I'm doing right in my practice. If it's a prophylactic, I don't need or don't feel I need to cross the neck of the pancreas. I would just place a short stent which is across the pancreatic orifice in the head of the pancreas, small stent which will either be biodegradable or a stent that's going to fall off or come off spontaneously in a week's time. But if it's a stent which is placed in with a therapy in mind, intended therapy, then I would aim to place a longer stent which is to cross the neck of the pancreas, not in a position. So you don't want to have a stent sitting at your distal end of the stent sitting where the neck of the pancreas is. It either needs to be below or across it. So the same concept in terms of you getting the wire across, you want to be careful that wire is not traversing through a branch of the PD along the neck of the neck of the gland, but across it. So prophylactic stent does not need to cross If it's a therapeutic or if it's therapy intended, then it should ideally. But the distal end of the stent should not sit there.
But for practical purposes, 5'3", 5'23", 5'5". So if I have 5'3", I prefer 5'3". For prophylactic stenting. Chances of it coming out.
I prefer 5'3". We have 5'3", 5'5" available here, so I would recommend 5'3", because then though it falls off itself quite often, and secondly, you know that you will never cross the. Yeah. I usually call our patients because our patients are different. They can disappear with the prophylactic stent and then come back and see you after 2 years and then say, oh, I didn't know that I had to take this out. So as a practice, we put it on our reports that this prophylactic stent has to be removed in 5 days or 7 days, whatever. Yeah.
Yeah, yeah.
Oh, it can stay inside forever, depending on where you put the stent. It may not come out. There are many factors, but you need to make sure that it has come out. I have actually got a gynecologist from Lahore who eventually ended up who had a 5'7" stent or 5'7", 5'9" stent placed as a prophylactic pancreatic stent. And that actually, when they wanted to take it out, it had actually migrated in. They couldn't take it out. Eventually got a stricture and in real bad shape. So we had to do pancreatic therapy. We actually took that stent out. We put multiple stents, dilated, but because this was not chronic pancreatitis stricture, so it actually responded very well to multiple stents, and she's asymptomatic now. So I think the important thing is that stent should not be long. This is one of the things that we do, and.
So we'll have to just close it a draw here, but I think very just quickly, extravasation of contrast. I hope you can all appreciate. What level do you think the leak is? Probably. So you see the filling in the pancreatic duct. Okay. Yep. Okay. This all is pancreatic duct. Spinous processes, I can't see the heads on.
What is happening here? You know, your duct is going like this and then going up. So what probably happened is that you put the wire and you were in a rush and the wire went through it. So if you're gentle, ideally if you have I find my used wires are better because they loop very easily. In this case, if you have a loop, your loop is so our practice is that we like to have loop in the back. The wire is looped, I'm comfortable. Start for the case, but and it will not go into sleep. That's one of the things.
So this is the main thing, sleep point over and over. This wire went in here at the and it was kind of a here. It took a side frame and somebody kept pushing it perforating the side frame. And then they injected it was all in, and that's all that happened.
And the other important aspect of injecting the pancreatic duct is you have to study the duct as it's being injected. So as the contrast is going up, you pay attention to what is the route that the contrast is taking. Because once it's filled like this, now you can't see anymore. So even if you didn't have the leak, you may not see the loop just because of the way the anatomy is. So your key image is going to be live image as the contrast fills an empty duct. So people will be looking around, or your assistant is injecting, you don't have the fluoro on, all of a sudden you turn it on, but by then it's too late. You can't figure out the anatomy.
Basically,
Yep. Okay. Good. Thank you very much. Yeah, sure.